not go through the entire chapter, chapter 3. I will tell you what page we technically will stop at. But starting on page 60. These are relaxation pressure curves. The first one specifically focusing on the lung. So, follow along with this picture here. So, when the lung is airless, when it's empty, it has zero recoil force. Makes sense. If the lungs are empty, there's no reason for it to recoil. As opposed to if the lungs are completely full, there's going to be a much greater recoil force. So, again, if you think about the more air we start to add, the increased recoil the lung itself will be encountering. Now the next picture, represents relaxation of the thorax, which again we said before, kind of those things kind of want to pull in opposite directions. So at the residual volume down here, the lung attempts to spring outward, right? Attempts to spring itself outward, creating a very strong negative recoil force. Following inspiration, up to about 70% of our vital capacity, okay, by about 70% of our vital capacity, there is really no recoil force of the thorax. Careful not to confuse, because we would expect the lung to have recoil. In this example, not necessarily the thorax. The lung will have recoil, but not necessarily the thorax. As we continue up to full total lung capacity, the thorax will recoil inwardly, generating a very strong recoil force. So I think between this slide and the previous slide, just focus on what location we're talking about. The previous one was the lung. This one is simply the thorax and dealing with recoil force or recoil pressure. All right, so going back from part 1. So this is just a picture of the slide from part 1. Now, resistance to lung inflation is from 2 different things. The first one being frictional resistance, the second one being elastic resistance. Now, elastic resistance, in the previous chapter we talked about lung compliance. That's what this really deals with. This elastic resistance is lung compliance. What we're going to focus on going forward here is really about frictional resistance. God bless you. I did write myself a note to make sure I mentioned to you guys. Now, normally, elastic resistance tends to be greater than frictional resistance. You and I, that's how our lungs are behaving right now. There's greater elastic resistance than frictional resistance in our normal lungs. Excuse me. However, with airway diseases, airway issues, airway problems, it is possible to see frictional resistance being higher than elastic resistance. So when I mentioned frictional resistance, anything that perhaps could cause the airway diameter to get smaller, to narrow, is going to increase frictional resistance. Instead of the airway being this big around as we breathe in, now it's this big around. That's going to create more resistance to gas flow. Airway diameters being much smaller. So frictional resistance, another way typically in practice, how we describe frictional resistance is we simply call it airway resistance. Now right now, with the exception of Jeremy, we don't have any significant airway resistance. Thanks for the lead in. I owe him some money. I'll tell him what, do this. I'm just kidding. So airway resistance, any resistance to airflow, we can actually measure. And we'll get into how we measure it in due time. But that could be something that we can measure and see what's going on with the patient at various points of time. To move gas through a tube, there is a driving pressure. There does have to be a pressure as we drive a gas through a tube. It is this driving pressure that is going to be required to overcome any sort of resistance to flow. Now again, looks like a mathematical formula. It is a mathematical formula, but it's not one that we're going to have to know just yet. In due time, we will be applying numbers to this. There will be some calculations for this, but we're not not ready to do those numbers and apply those numbers to this yet. But resistance to gas flow through a tube. Picture this is the airway. All right, this is the airway. Here's our trachea. Here's our right main stem bronchus. Here's a terminal bronchial airway. Whatever along our airway path. Resistance to gas flow through a tube is expressed as a pressure decrease between the inlet and the outlet divided by the flow rate. Now, flow rate, that funny looking V with a dot above it, represents flow rate. I actually try to make sure I use the correct initials sometimes because I can't find the V with the dot above it. I can only put a V. Sometimes you'll see on some of my slides just a V when I intend to put a V with the dot above it. So just be careful there. If there's ever a question, please ask me. Because sometimes if there's just a V, that can be interpreted as volume. So if there's ever a question you're not sure, please ask me and I'll make sure, yeah, oh yeah, this is supposed to be that funny looking V with the dot above it. All right, so for resistance, again, comparing point A to point B basically. If there's any, let's say, narrowing of an airway, that's going to require a greater driving pressure to drive that breath through the airway. All right, the greater the friction between the gas molecules themselves, viscosity we talked about in the first class, and between gas molecules and the tube walls, the greater the opposition to flow. So again, narrower airways that are supposed to be this big around but now are this big around, maybe from disease or illness, is going to increase frictional resistance, or in other words, increase airway resistance. Speaking of airway resistance, so abbreviated R for resistance. I forget what this AW stands for. Can you help me? Oh yeah, airway. Airway resistance. I'm here all week. That is the acronym for airway resistance. The big R stands for resistance, the AW for airway, or what we typically get used to in class just saying the raw, R-A-W, the raw. So in the lungs, airway resistance is measured in units of centimeters of water per liter per second. Centimeters of water per liter per second. Again, this is the frictional resistance to gas flowing through the airway. For a given flow rate, a large pressure drop or decrease across the airways can indicate a high airway resistance. Now it is important, you learned last week what a normal lung compliance is, right? So that was the elastance. Here's airway resistance. Normal airway resistance is approximately 0.5 to 1.5 centimeters of water per liter per second. 0.5 to 1.5 centimeters of water per liter per second. Now I will say this, numerically, would you say a number that's 0.5 to 1.5, that's a small number? 0.5 to 1.5, small number, as opposed to say it's 20 to 30 would be a higher number? Think about you breathing right now. Do you feel, except for Jeremy, no, I'm just kidding. Do you feel any resistance to airflow? You don't. Now, if I gave you a straw and said, you're only allowed to breathe through the straw, I'll let you take the elevator down to the ground floor, but you got to take the stairwell back. And the only way you can breathe is through that straw. Can't breathe through your nose. Can't leak out here through your mouth. No, we'll use nose clips. We'll tape your mouth shut around that straw. And now you got to climb up the stairs. Would that be, you pass out, would that be resistance to flow? There's your asthmatic patient in an asthma attack when their airways, instead of being open normally, are now like this. And that's the only way they can breathe. Okay? Asthmatic patients have bronchospasm, bronchoconstriction. Their airways narrow like a straw. That's the best analogy. I'm not going to make you do that by any means. I will say this, about 15 years ago, I had a class actually do that. We were in a room at the end of the hall here. There was a stairwell right outside. I thought, bring in some straws. We're going to do this activity. I said patience. I had students get ready to pass out on me. I'm like, all right, that's a bad idea, John. I'm never going to do that ever again.
You haven't signed a waiver at least.
I guess I could have. And we were only on the second floor, so it wasn't like they were climbing 3 flights. It was just one flight. Shouldn't be that too bad. Shouldn't be that bad. I guess I should have prefaced it if you're already an asthmatic patient, do not participate in this activity. I had a couple of asthmatic students at that time, like, oh man, and they're the ones I'm more worried about. Okay, take the straw out of your mouth, breathe normal, purse lip, breathe through purse, whatever. So learn my mistake that way. So I will describe it like I just did, but we will never do it. But if you're by yourself at home and you want to experience what it's like that being an asthma attack, go for it.
Lord, don't do it alone at home.
You didn't hear that from me. I didn't say that on the video. All right, so the amount of air resistance does depend on the radius of the airway, how open that airway is. God bless you. God bless you. Normally during inhalation, the diameter of the airway does expand a little bit. Normally. When we exhale, it does constrict a little bit, but that's normal. That's normal for us. When we have a patient, like an asthmatic patient, or maybe a patient with COPD, or any other illness or disease that can cause the radius or diameter of the airway to get smaller, that's going to be an increase in airway resistance. So with the asthmatic patient or even the COPD patient that may experience bronchoconstriction or bronchospasm, that airway diameter gets smaller. Another example, and you probably will encounter this example more than the asthmatic patient. What happens to the airway when I have an abundance of secretions building up? What happens to the diameter? If there's a bunch of secretions in the airway, that diameter is going to be smaller because of all maybe the junk that's in the airway. So the diameter of the airway, instead of being nice and large, if it's loaded with lots of mucus, which there's plenty of illnesses and respiratory diseases that do deal with increased concentrations of mucus, guess what happens to the airway resistance? It increases, it goes up because the diameter of the airway gets smaller. In that example, not necessarily from the smooth muscle constricting like we see with an asthmatic and an asthma attack, but just simply because of all the buildup of mucus that may be inside those airways. All right, flow regimens, or another way to say regimen is pattern. Flow pattern. There's three primary flow patterns that move through the airways: laminar flow, turbulent flow, and a tracheobronchial or transitional flow, which is really the spot between the two. Okay, if I was to put it in order, maybe turbulent, transitional, and laminar, if I was going to put it in some sort of order here. All right, laminar flow. Laminar flow is considered smooth, streamlined, organized flow. The gas will overlap in cylindrical layers. You can see here's some laminar flow. This gas is in this streamlined form. Under laminar flow conditions, the pressure required to produce a given flow rate through a tube or airway is defined by Pucell's law. Dang it, another law. Two different classes, don't get them confused. Two separate classes, but Pucell's law. Again, don't worry about the formula. The formula deals with length and tube radius and diameter, among a few other things. What was the other things I forgot to mention? Oh, gas velocity was another one. Don't worry about Pucell's law other than what it's going to eventually tell us. What it's going to tell us is the pressure required to drive the flow through a tube must increase when the tube radius decreases. I think that makes sense. If the tube radius decreases, it's going to require more pressure to drive the air through there. Okay, that's what Pucell's law tells us. It also tells us, based on that equation, based on that formula, which you're never going to have to solve, so don't worry about it, a person must exert 16 times more work or effort to maintain the same flow if the airway diameter was to be reduced by 1/2. Okay, so if the tube radius decreases by 1/2, how much more force is going to have to be generated? 16 times more force will have to be generated to drive the same flow through the airway or through the tube. But what? Okay, I'm going to go to the next slide and I'll say what I'm about to say. So, Again, tells us that if the tube radius decreases, so in this example, here's the tube radius 1 centimeter, here's the tube radius drops by exactly 1/2, so it's 1/2 centimeter. How much more pressure is going to be required? 16 times more pressure. So if over here it only required 1 centimeter of water pressure to drive the breath through to maintain the same flow, it would require 16 centimeters of water pressure to drive that same flow through the airway. I think I just answered my question. If the airway radius is decreased by 50%, how much more pressure is required? Again, 16 times. My follow-up to that, and I'm sorry if I didn't put that last bullet point on the slide I posted. Is it there? Okay, sorry. Go ahead and add it yourself. What if the patient cannot generate the increased effort? What if the patient's not capable of generating 16 centimeters of water pressure more? What's going to happen?
Ventilate?
What about ventilate?
You feel like you'll need to ventilate?
Or the
feel
what
like a
about the
baby-
patient's ability to ventilate?
they won't
The
be-
patient's ability to ventilate themselves is going to significantly drop. Okay, it's going to significantly drop. So if the patient cannot generate the increased effort, picture our patient, our elderly patient, our patient who has significant muscle weakness. They're not able to generate that 16 times more force or effort. You know how much their flow will drop by? Now this is not on the slide, so write this down. You know how much their flow will drop by? One-16th of its original flow. If they're not capable of generating that increased, 16 times increased force. If not able to do that because of severe muscle weakness, whatever, the flow rate through the airway will drop to 1/16 its original flow. Again, based all on his law, Hussell's law. Now you and I should be able to generate that extra force or effort because we're healthy. My poor sick patient, severe muscle weakness patient, might not be able to. And those are the patients we encounter in the hospital. Those are the patients we eventually see, they're not doing so well. These are the patients we'll eventually be hooking up a mechanical ventilator or some sort of ventilatory assistance for because they're not capable because of the severe muscle weakness they're experiencing. They can't generate that increased force.
Is there any way for us to like help increase their muscle, or are they going to be on a ventilator for like the rest of their life?
Not like that. I wish there was a pill
I mean,
or
it's like-
medicine
it's
that
like
we could.
working out, you know what I mean? You still have to like strengthen your muscle, you still have to like tone your muscle. So
Right,
it
so
takes time.
it's going to take time, correct, absolutely it's going to take time. But, you know, in the interim, we would have to artificially ventilate them because they would not be able to maintain 1/16 of what they originally were trying to do. All right, so laminar flow, turbulent flow. This airflow is chaotic. Churning, swirling airflow, swirling currents of airflow, as opposed to the nice, smooth, streamlined airflow we see with laminar airflow. Gas molecules are swirling all over the place, forward, backward, sideways, back and forth. Gas flowing through narrow and sharp, seen with gases flowing through narrow, sharply branching airways, but because of all this chaos when it comes to airflow, the airflow sounds tend to be much louder. Laminar sounds tend to be much quieter because of the streamlined flow. Turbulent airflow sounds louder. Again, when we're listening with our stethoscope, we can hear that turbulent airflow as opposed to the laminar airflow that we still can hear, but it's going to definitely be much quieter. The tracheobronchial or transitional airflow, again, it's where airflow has characteristics of both. Sometimes we say that's that transition point between turbulent and laminar airflow. And we'll get to kind of a specific location here in just a sec. I came across this and thought it was a good way to kind of look at flow. Laminar flow, nice, smooth, sorry, get to the right side here. Nice, smooth, streamlined. Turbulence, the crazy, chaotic airflow. transitional, or tracheobronchial is kind of that transition point between. If you're listening for sound or sound quality, laminar flow tends to be quieter sounding, where turbulent flow tends to be much louder when you're listening and auscultating. On page 66, see, I'm good about writing page numbers on this. On page 66, it talks about breath sound and types of flow in the airways. Okay, so breath sounds over the trachea in large bronchi. Higher pitched, turbulent, harsh sounds. That's why we will typically refer to these breath sounds as tracheal or bronchial, because that's the kind of the location we're hearing them out at. But again, louder sounds. Breath sounds over the lung periphery, the far away parts away from the trachea. Softer sounds, lower pitched, gentler sounds. We sometimes call these vesicular breath sounds. I don't think it's this Tuesday, maybe the following Tuesday we'll do a whole breath sound type lecture. But those sounds are the laminar sounds, laminar flow sounds. So if you're to look here at this person and where we're hearing sounds, the bronchial area here over the large airway, those are going to be the more turbulent, louder sounds we hear. By the time gas reaches out here, the lung periphery, the V for vesicular breath sounds, quieter sounding. We still can hear it, but definitely quieter in sound. Bronchovesicular, which is kind of the transition point between the bronchial or tracheal breath sounds and the vesicular breath sounds, there's your transitional airflow. And so they can have kind of similar sounding between both the louder and softer sounds.
Do the sounds have anything to do with the, wow, I totally forgot what I was going to say.
That's right.
I'll let you know if it goes to.
Okay, hang on to it. It'll come back to you. So bear with me. It worked this morning, so I don't know if this is going to work now with you guys, but I want to show you the example of what bronchial breath sounds, more turbulent breath sounds sound like, and again, normal sound like, versus vesicular, more laminar flow breath sounds, what they sound like. So I hope this quality of the sound works. We'll give it a shot. Which sounds were louder, bronchial or vesicular?
Bronchial.
Bronchial. Airflow with bronchial breath sounds are more turbulent versus vesicular. Again, these are still normal breath sounds. You can hear, again, we're out in the lung periphery. Again, still normal breath sounds, but isn't the sound much softer, much quieter? Because that's where you're hearing laminar airflow. Laminar airflow moving through. Like I said, not tomorrow, but I think then the following Tuesday, I'll do a whole thing on breath sounds, and hopefully it plays right in here. All right, so upper airway tracheobronchi. That's where we're hearing those turbulent airflow patterns. Normally, the upper airway tracheobronchi account for about 50% of the total airway resistance in a normal individual. The bronchioles or distal air spaces when we're hearing that laminar flow, much deeper, further into the lung parenchyma. The smaller airways definitely account for much less of the total airway resistance. And why is it so much less, even though the airway diameters should be smaller than up here? It's because there's much greater surface area. They spread out and they're much larger areas. Even if one passage was to be blocked, there's multiple passages that are going around them. So as opposed to maybe something larger being blocked, a trachea or bronchi, that definitely would prohibit airflow. Overall resistance is typically much lower, God bless you, in the smaller airways. Again, because there's much greater surface area in the smaller airways as opposed to the upper. However, patients with severe emphysema, chronic bronchitis, or even asthma, specifically during an asthma attack, airway resistance to flow in the lower airways may equal or even exceed that of upper airway resistance. Now, normally that should not be happening to us, but when we see those patients that are in severe distress, that are having severe problems, and that lower airway is creating high airway resistance, those are the people we're really struggling with to work with and try to get their airways opened up. That's why we give the breathing medications, the bronchodilating medications to try to get their bronchi and those lower airways opened up. Did you remember?
I think so.
Okay.
So the flow type and the sound and the resistance are all related.
They're all interrelated, absolutely,
Okay.
absolutely. Oh, that was it. 16? Way too short for me. All right, any questions before I get up? I don't mind go ahead and doing some questions and then fielding questions for you guys or anything from this or previous lectures that we did. But let me go ahead and give you the few questions here. I'm sorry, yes?
I was also going to say page numbers too.
Okay, thank you. You said that. All right, so let me pause there. So we started on page 60, if I'm not mistaken. Yeah, page 60 from this part. We're going through the end of page 65. 65. Now just bouncing back one. This was actually from page 66. It's the only thing from page 66 that if you wanted to look back at it, you can. But everything to this point is through page 65, meaning from page 66 through the end of the chapter, which ends on page 78, we are not discussing in this class at this time. Okay? So to narrow down your studies, narrow down your focus, not that anything additionally is not important, but I know it's nothing I'm going to test on and it's nothing I'm going to make you responsible for knowing about just yet. I will say this textbook does come in with certain expectations that there's certain things you should know that you would know already, which of course you don't. And so that's why I kind of limit certain things. We'll talk about this, we'll introduce that, but we're not going to talk about this yet because there's things that we haven't talked about yet, which would be foundational for some of this other stuff. So not that it's not important, but it's not important to us just yet. So this chapter concludes for us at page 65, 66 if you count that thing about the breath sounds, but really ending on page 65. All right, let me give you a few questions here, and then you guys are more than welcome to ask me any questions. All right, first question: what is a normal raw or airway resistance? Now, I'm just going to go ahead and say I try to be pretty good the first semester. If I give you an abbreviation, I try to put something in parentheses to define it. But I'm just saying, in due time, I should not have to tell you what raw stands for. Again, I will early on, because again, everything's so new. But at some point, make sure you know what raw actually means, even though I might not say airway resistance. So what do you think? What's the correct answer?
Hamburger meat.
This one is B, correct, 0.5 to 1.5 centimeters of water per liter per second. Now, obviously, the units for this answer option were all the same. So there was no fear that John flip-flopped things around just to try to be tricky. So that's fine. Now the numbers, if you notice the numbers, some of these numbers, it's a normal number for something in some other instance. Again, get used to it, especially the more numbers we're going to try to have to commit to memory. Make sure you know truly what they are. It's just not a number that you recognize, because I'm going to put plenty of numbers that you recognize a number, but obviously, what we talked about today, 43.8, that was a number for something, wasn't it? We round up, called 44. Yeah, had nothing to do with airway resistance, right? So just be careful on that. And 0.2 to 200, I know that numbering was found somewhere, but all right. So this one was B. Everybody okay with this one? This one was B. 0.5 to 1.5. If I gave you a patient scenario, let's just say, using this number, and I said, this morning, your patient had an airway resistance of 0.5 centimeters of water per liter per second. This morning. This afternoon, it went to 1. Early evening, it went to 1.5. Later tonight, it went to 3. Midnight, it went to 5. Tomorrow morning, it's now 8. What would that tell you about the patient? Their airway resistance is doing what?
Increasing.
Increasing, meaning perhaps their airway diameter is getting smaller and smaller and smaller each time we check it. Now, what could cause airway diameter to decrease? We only really mentioned 2 things.
COPD.
Asthma, airways narrowing, and secretions. 2 primary things to remember why one's airway resistance could keep increasing. Airway diameters that are getting smaller and smaller. Again, asthma is the easy example, but COPD would be another. COPD fits pretty much everything at some point, right? When in doubt, pick COPD. Don't do that, because I'm gonna flip it up one of these days, and it's not gonna be the right answer.
Okay.
But secretions that have been slowly building up over time. Slowly building up over time. And the respiratory therapist, the nurse, and doc, nobody ever suctioned the patient. Secretions just keep building up, building up, building up, building up. And airway resistance that's being measured keeps getting higher and higher and higher and higher. Now, do you think I'd be able to hear a buildup of secretions? Of course I can. But we'll get to all that in due time. This is just looking at one specific factor. All right, but the correct answer here was B. All right, next question. What's the name of the normal breath sound heard over the trachea? Is that vesicular, wheezes, bronchial stridor, or crackles? Bronchial. Could even call it tracheal, but bronchial here. And some of these others we haven't even talked about yet, and we'll talk about them in time. This gives you more things to have to know and recognize. So this one's bronchial. So this one is C. Is it bronchial? Yeah, bronchial.
Don't do that.
Now, if you have us choose between bronchial and tracheal,
I think when I put tracheal on here, I think it's a dead giveaway at that point. Yeah. So that's why I use the term bronchial. But sometimes bronchial or tracheal breath sounds can be used synonymously. But like I said, if I put tracheal as an answer, I think it's a dead giveaway. Sound heard with the trachea, tracheal. So I use bronchial here. All right, next question. According to Purcell's law, if an airway's radius decreases to 1/2 its original size, what pressure will be required to maintain the original flow through the airway? Is that 2 times, 4 times, 8 times, or 16 times more? It is D, 16 times more pressure. 16 times more pressure. And if the patient cannot generate that increase in pressure, what's going to happen to flow? It would reduce to 1/16. Is it still behind me? 1/16. Right? 1/16 its original flow. If the patient was not able to generate that extra pressure or extra force. All right, one more question. Which of the following is a normal lung compliance? Is that 0.2 liters per centimeter? Is that 2 liters per centimeter? Is that 20 milliliters per centimeter? Is it D, 200 milliliters per centimeter? Is it E, 0.2 milliliters per centimeter? Or F, 200 liters per centimeter? I hear A. I hear A and D. Could it be 2? More than one right answer? How dare I do that? Correct answer is A and D. A and D. Again, you can tell clearly the units are a little bit different for some of these, which again creates added confusion or added discomfort, right? I could ask it either way. Remember the last week I asked the same question. There was only one answer there, but I flip-flopped the units. Can't remember how I exactly did it, but changed the units around a little bit to get you to want to pick something else. So just make sure it's either 0.2 liters or 200 milliliters per centimeter of water. Make sure that was my last question. Okay. All right, last question. What questions do you guys have for me?